Today's quiz is all about cyclooxygenase 2 inhibitors, better known as COX-2 inhibitors, a vital class of drugs with significant roles in managing pain and inflammation. This quiz features 10 multiple-choice, scenario-based questions designed to test and strengthen your pharmacology knowledge. Each question comes with 5 options, followed by the correct answer and a clear explanation to enhance understanding. For a detailed review of COX-2 inhibitors and their key concepts, don't miss the companion video linked in the description. So, let's begin. Question 1. Mrs. Thompson, a 68-year-old woman with a history of osteoarthritis and hypertension, presents with persistent joint pain unrelieved by paracetamol. She is prescribed celecoxib. Her past history includes peptic ulcer disease 5 years ago, now resolved. Laboratory results show normal renal function. She asks how the drug works. Which of the following best explains the mechanism of action of celecoxib? Option A. Irreversible inhibition of COX-1 in platelets. Option B. Selective inhibition of prostaglandin synthesis via COX-2 blockade. Option C. Blocking leukotriene formation by inhibiting 5-lipoxygenase. Option D. Direct antagonism of prostaglandin receptors in joints. Option E. Inhibition of phospholipase A2 reducing arachidonic acid availability. The correct answer is option B, selective inhibition of prostaglandin synthesis via COX-2 blockade. The explanation is that celecoxib specifically targets COX-2, which reduces prostaglandin synthesis involved in pain and inflammation. By sparing COX-1, celecoxib lowers the risk of gastrointestinal irritation compared to traditional NSAIDs. This selectivity makes it useful for patients with prior peptic ulcer disease who require long-term therapy. The other options describe mechanisms of different drug classes such as aspirin, leukotriene inhibitors, or corticosteroids. Question 2. Mr. Carter, a 55-year-old man with ankylosing spondylitis, has been managed on etoracoxib for pain relief. He has no prior GI history but is a smoker and takes low-dose aspirin for cardiovascular prophylaxis. His physician reviews him regarding indications for COX-2 inhibitors. All the following are correct indications for COX-2 inhibitors except Option A. Rheumatoid arthritis. Option B. Osteoarthritis. Option C. Dysmenorrhea. Option D. Stroke prevention. Option E. Acute pain management. The correct answer is option D, stroke prevention. The explanation is that COX-2 inhibitors are not indicated for stroke prevention, and in fact, they can increase cardiovascular risk. These drugs are instead approved for managing inflammatory conditions such as rheumatoid arthritis and osteoarthritis. They are also used for dysmenorrhea and acute pain relief when gastrointestinal protection is desirable. Therefore, stroke prevention is not a therapeutic role for COX-2 inhibitors and may actually pose harm. Question 3. Mrs. Johnson, a 72-year-old with chronic kidney disease stage 3 and type 2 diabetes, is prescribed celecoxib for osteoarthritis. After 2 weeks, she develops worsening edema and rising serum creatinine, from a baseline of 1.4 mg per deciliter to 2.1 mg per deciliter. Which of the following best explains the adverse effect observed? Option A. COX-2 inhibition reduces renal prostaglandin-mediated vasodilation. Option B. Increased aldosterone antagonism leads to sodium retention. Option C. Direct tubular toxicity through drug accumulation. Option D. Increased nitric oxide causing renal vasoconstriction. Option E. Enhanced potassium secretion in distal nephron. The correct answer is option A. COX-2 inhibition reduces renal prostaglandin-mediated vasodilation. The explanation is that prostaglandins help maintain renal blood flow, especially in compromised kidneys. COX-2 inhibition reduces prostaglandin synthesis, which decreases vasodilation of the afferent arteriole, impairing renal perfusion. This can lead to fluid retention, edema, and worsening kidney function, particularly in patients with pre-existing renal disease. The other options do not explain the hemodynamic mechanism of NSAID-related renal impairment. Question 4. Mr. Anderson, a 63-year-old man with ischemic heart disease and hypertension, is advised about the risks of rofecoxib before initiating therapy for severe osteoarthritis. Which of the following is the most important cardiovascular adverse effect that led to withdrawal of this agent from the market? Option A. Increased risk of myocardial infarction. Option B. Worsening of heart failure. Option C. Induction of atrial fibrillation. Option D. Sudden cardiac death. Option E. Pulmonary embolism. The correct answer is option A. Increased risk of myocardial infarction. The explanation is that rofecoxib was withdrawn due to strong evidence linking it to an increased incidence of myocardial infarction. COX-2 inhibition disrupts the balance between prostacyclin, which is protective, and thromboxane, which promotes clotting. This imbalance favors thrombosis and raises the risk of heart attacks. Other listed cardiovascular problems may occur, but myocardial infarction was the defining safety concern. Question 5. Mrs. Walker, a 29-year-old woman with primary dysmenorrhea, is being counseled on analgesic therapy. She is not pregnant and has no comorbidities. Her doctor is weighing between COX-2 inhibitors and non-selective NSAIDs. Which of the following is not a key comparative property of COX-2 inhibitors relative to non-selective NSAIDs? Option A. Lower risk of gastrointestinal bleeding. Option B. Higher risk of cardiovascular events. Option C. Equal efficacy in pain reduction. Option D. Better antiplatelet effect. Option E. Preservation of gastric mucosal protection. The correct answer is option D, better antiplatelet effect. The explanation is that COX-2 inhibitors do not inhibit platelet aggregation because platelets primarily express COX-1. This means they lack the antiplatelet benefits of non-selective NSAIDs like aspirin. While COX-2 inhibitors preserve gastric protection and show equal pain relief efficacy, they are associated with higher cardiovascular risks. Therefore, better antiplatelet effect is not a feature of COX-2 inhibitors. Question 6. Mr. Harrison, a 78-year-old with rheumatoid arthritis, mild dementia, and reduced renal clearance, is prescribed celecoxib. He takes digoxin and warfarin. Which of the following drug interactions is least important when considering COX-2 inhibitors? Option A. Increased INR with warfarin. Option B. Reduced renal clearance of digoxin. Option C. Decreased antihypertensive efficacy of ACE inhibitors. Option D. Enhanced sedation with benzodiazepines. Option E. Additive nephrotoxicity with diuretics. The correct answer is option D. Enhanced sedation with benzodiazepines. The explanation is that COX-2 inhibitors do not have pharmacologic effects on the central nervous system that would enhance sedation from benzodiazepines. More clinically relevant interactions include potentiation of warfarin leading to increased INR, altered renal clearance of digoxin, and reduction in the effectiveness of ACE inhibitors. They may also increase nephrotoxicity risk when combined with diuretics. Thus, benzodiazepine interaction is not significant in this context. Question 7. Mrs. Edwards, a 35-year-old pregnant woman at 30 weeks, presents with severe knee pain. She asks about taking celecoxib. Which of the following statements best describes the contraindication of COX-2 inhibitors in late pregnancy? Option A. Risk of premature closure of ductus arteriosus. Option B. Increased uterine contractility causing preterm labor. Option C. Maternal hypertension due to COX-2 blockade. Option D. Increased risk of neural tube defects. Option E. Impaired placental glucose transport. The correct answer is option A. Risk of premature closure of ductus arteriosus. The explanation is that COX-2 inhibitors, like other NSAIDs, can inhibit prostaglandin synthesis, which is necessary to keep the ductus arteriosus open in utero. In late pregnancy, this can cause premature closure, leading to fetal pulmonary hypertension. This is the key reason for contraindication in the third trimester. The other options do not represent the established risk profile of COX-2 inhibitors. Question 8. Mr. Robinson, a 64-year-old with chronic low back pain, is being trialed on COX-2 inhibitors. His physician wants him monitored during treatment. Which of the following is the most important monitoring parameter for long-term safety in this class? Option A, liver function tests. Option B, blood glucose levels. Option C, serum creatinine and blood pressure. Option D, serum calcium. Option E, thyroid function tests. The correct answer is option C, serum creatinine and blood pressure. The explanation is that COX-2 inhibitors can impair renal perfusion and cause elevations in serum creatinine, especially in patients with underlying kidney disease. They may also increase blood pressure by reducing renal prostaglandin-mediated vasodilation and sodium excretion. Monitoring these parameters is critical for detecting early renal impairment or cardiovascular complications. Other lab tests are not as directly influenced by COX-2 inhibitor therapy. Question 9. Mrs. Mitchell, a 58-year-old woman with rheumatoid arthritis, is given a prescription for one of the following COX-2 inhibitors. She is told that this drug has the shortest half-life among them and may require more frequent dosing. Which drug is it? Option A, celecoxib. Option B, etoracoxib. Option C, valdecoxib. Option D, percoxib. Option E, lumiracoxib. The correct answer is option E, lumiracoxib. The explanation is that lumiracoxib has a relatively short half-life of about 4 hours compared with other COX-2 inhibitors, which often have much longer half-lives. This pharmacokinetic property necessitates more frequent dosing to maintain therapeutic levels. By contrast, agents like etoracoxib and celecoxib have longer half-lives that allow once-daily administration. Therefore, lumiracoxib is the correct answer. Question 10. Mr. Phillips, a 60-year-old man with chronic osteoarthritis, is being considered for pain control. His physician compares celecoxib with naproxen. Which of the following statements correctly distinguishes the two drugs? Option A, celecoxib provides superior antiplatelet activity than naproxen. Option B, naproxen has lower cardiovascular risk compared with celecoxib. Option C, celecoxib is more ulcerogenic than naproxen. Option D, naproxen selectively inhibits COX-2 over COX-1. Option E, celecoxib has a longer half-life than naproxen. The correct answer is option B, naproxen has lower cardiovascular risk compared with celecoxib. The explanation is that naproxen, a non-selective NSAID, has a more favorable cardiovascular safety profile compared with COX-2 selective inhibitors like celecoxib. This difference is due to the balance between prostacyclin inhibition and thromboxane activity, which is shifted more with COX-2 selective drugs. However, naproxen carries a higher risk of gastrointestinal side effects compared with celecoxib. Thus, cardiovascular versus gastrointestinal risk is an important distinguishing factor. Conclusion. That wraps up our revision on COX-2 inhibitors. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation.